to walk through a deck. I'm going to bounce through between a deck, some online visualizations that we've put together, and kind of tell you a little bit of a story of what I see going on here through my lens using my healthcare data. So let me go ahead and share my screen here, and we'll get going. So I presume that everybody can see this, hopefully. I'm looking at this in terms of the 18% of the US economy that's in healthcare. And I'm going to talk about it with respect to two issues. One is the economics that are affecting the US healthcare industry. And two, what I'm seeing in data specific to COVID, and have some thoughts around what the longer term impact might be. To start us off, I don't know if any of you are familiar with SafeGraph. So this is a point of service foot traffic tracking industry site. They're supplying information to the White House, as am I. But I just thought I'd show you a little bit of their information here. So this is looking at industry level patterns of consumption pre-post shutdown. And the day of March 15th really will live in infamy in the United States. That's the day that everything changed, that we put the brakes on the US economy. And you'll see that in all my visualizations, that March 15th was an important day. But this is from SafeGraph. And this is showing by sector of the economy, industry level patterns. And you can see that movie theaters, well, they basically went to just pretty close to zero relative to one being the pre-period. And again, please put yourself on mute for those who are just joining, because I hear lots of background. And then you can see that other areas, general merchandise stores, they were off a bit. Airports clearly cratered, but it varies by industry segment. If you look at it by brands, I have been out and about. I can't sit on my cattle farm at home, and I go to Home Depot a lot. And seems like everybody else does too, because Home Depot relative foot traffic is actually up post March 15th by almost 50%. You got everybody trapped at home, and they're figuring out things to do in their houses. Whereas if you look at Starbucks, it's off by about 50%. So here are some big brands here, again, showing the change that you see pre-post March 15th. Step back here. If you look at this graph here and you notice hospitals, that's my indicator for medical care. And that looks like it's off about 45% pre what it was. And that is derived from foot traffic. What I'm seeing in the claims data is very similar to that. So some of you might be aware, last year I started doing some work with the administration. Here's a picture of me with in November of last fall talking about price transparency. Because of the work I've done with the administration and HHS, they reached out to me in early March, basically the first week of March, and said, Larry, we know you have access and live your life in the healthcare claims data world. We're flying blind. We're trying to put together as many pieces of information that will facilitate our doing planning. And so if you could work on providing us a real-time data feed around healthcare consumption and respiratory diagnosis in America, that would be beneficial. So I worked on spooling that up, and every night I deliver a file that's used by the Council of Economic Advisors and others in the administration to give them a sense for what's going on in the United States in healthcare. And given that activity, I'm constantly working with this data. So I thought I'd pull a little bit from what that feed looks like and paint you a little bit of the picture. In short, prior to April 1st of this year, there was no way to specifically codify COVID-19. And in healthcare, we talk about things in terms of ICD-10 codes, and there was not an ICD-10 code prior to that. So if you were diagnosed if you were sick in January or February or March, and you might have had COVID, they couldn't code it that way. So they had to code it as something else, and probably influenza, respiratory illness not otherwise classified, all these kinds of conditions. So I put together about 80 ICD-10 codes that form the basis for the respiratory diagnosis I was tracking. And I started looking at that at the county level by age band and by place of service. So that's kind of one of the feeds I was creating. Let me see if I can mute everybody. Let's see. Do I have the ability to mute everybody? I'm sorry. Mute yourself, please. And then the other data feed that I created was a measure of clinical activity. So how much are people going and consuming medical care every day? And again, looking at the county level by place of service and age bands. So that's the kind of information that I'm going to be telling stories from today with you. So let's see if I can advance this. So first, let me tell you where data comes from. And for those who don't live in the healthcare world, I thought it'd be useful. I drew this little picture. This is me on my Surface Pro. But think about yourself going into the doctor down there, and you've got that purple guy at the bottom. And you sit there across the table from your physician, your provider, and they're basically spending all their time typing in all this information into an electronic health record during that visit. And they're codifying your diagnoses, what they're doing to you, all of that kind of stuff. Nightly, weekly, periodically, what happens is that gets transmitted electronically in something called an 837 electronic submission. And it has things in it called CPT codes and ICD-9 or ICD-10 codes, place of service, that all gets submitted electronically into, at the top, a company called the Switch. And these switches, think about them as being the hubs of pipelines. And they get all of that data flowing into switch companies. And one of the nation's largest is located here in Nashville by the name of Change Healthcare. Other ones include Optum, Availity down in Jacksonville, Florida. But there's a number of them that aggregate all of the electronic claims in the United States, package it up and send it to insurance companies. And what my data is that I work with every day is 837 electronic claim submissions across the United States that give me visibility into medical care that's delivered and who's delivering it, what treatments were delivered, where it was delivered, all of that kind of information. It's all de-identified. I don't know anything about the individuals, but I know everything about the encounter in terms of the diagnosis and the treatments and procedures performed and who's doing it. So this is just a little bit of background on that data. And so the data that I'm working with here in terms of the real-time data stream is not the full warehouse that I typically work with, but is aggregated and reflects about 60% of all commercial medical care claims in the United States. So, you know, the commercial market is probably about 50% to 60% of all individuals are in commercial health insurance plans through employers. And I'm getting a pretty good read on that activity. I get my claims every day. But from the time that a provider on Monday codes the claim, submits it electronically to the clearinghouse, and for me to put it in my hands in my warehouse, I usually start getting visibility about 3 days post-service. And we do a bunch of math to extrapolate what the full volume would be in that provider on that given day and whatnot. Interestingly enough, we're sitting here today with about 1.4 million Americans having COVID-19. I see in my data 280,000 unique individuals who presented at a healthcare provider for medical care who have COVID-19. The ICD-10 code that was created on April 1st, that is UO71. So it's roughly about 23% of the US case count. I have visibility into those cases. So that's the data asset that I'm going to be focused on talking about here today. Let me switch over and start making some observations here, and let me see if I can jump over to this one. So this is looking at, hopefully you guys can see a screen here, a website that I did a visualization on Flourish. This is looking at respiratory diagnosis in America, starting the week of January, ending January 11th. And if the color is yellow, the level of respiratory diagnosis in that county is the same, is normalized to the first 2 weeks of January. As the colors get hotter, redder, that indicates more and more respiratory diagnosis being observed in those counties. As it goes green, it drops off. It's decreasing. So I'm going to run this little visualization, and it's advanced week by week. And so you can see here, as you get into the first week of February, you've got a lot of red going on, particularly in the eastern half of the United States. And you can see areas down in the southern, North Carolina, South Carolina, with a lot of respiratory diagnosis. Now, this could be COVID, or it could be influenza. But there's a lot of activity in the eastern part of the United States much earlier than March 15th. Continuing to move this forward, and it dies out as we get into March. You see some areas that are markedly hot in southern Illinois. You see in Washington State, in Oregon area, northern, the UP of Michigan, but Southern California, New Mexico, very little activity going on. And then rolling it forward, now we've crossed the March 15th line, and nobody is going and getting diagnosed for anything in the United States, pretty much. And that includes respiratory illness as well. And so what you saw is this cratering of clinical activity, and I'll show you that as well, but also relative to January, the diagnostic prevalence, generally speaking, of respiratory conditions dropped precipitously. And this is continuing it out. So you see here, there's your hotbed in New York City. This is mid-April. So you see some activity there. You see some isolated pockets here in Utah as well. But by and large, most of the country is pretty innocuous. This is continuing forward here as we now enter the last, up through the end of last week, where most of the United States has, the respiratory prevalence is de minimis compared to where it was before. So that's looking at all sites of service and showing you kind of the trends in respiratory diagnosis in the country. I have a strong belief that the COVID-19 activity was probably much more prevalent, much earlier than the March timeframe in this country. And that will be confirmed over time. But if you look here at the beginning of February and you're looking at northern Massachusetts, you have respiratory illnesses and prevalence that's markedly higher than it was in January. I think it's very possible that the cat was out of the bag much earlier than we took action on. And I think many of you might be tracking the studies out of Stanford and Santa Clara, California, the Brigham Hospital random surveys in Cheatham, Massachusetts, where they're finding that a significant portion of the population is asymptomatic, but test positive for COVID-19. Locally here, 2 weeks ago in Wilson County, we had the case of the prison in Trousdale, where they randomly tested the population of staff and inmates and found 1,300 inmates were positive for COVID-19. That said, 98% of them were asymptomatic. This is part of the challenge I have with the case, the testing and the narrative that's out there. If 98% of the people are asymptomatic but testing positive, does that affect our thought process of how we should be responding to this as a society? Let me go back over to my deck here. So what happened nationally in this country? And I'm going to show you a little bit some national trends here. This is looking at office visit activity in the United States. This isn't for respiratory illness. This is for all medical care. And March 15th is right here, the magic day. Hopefully you guys can see me moving my pointer up and down on March 15th. The blue line is the smooth moving average. And this is all normalized to activity in January. So we're up about 10% over January and early March, and then we crater. All the way down to when we're sitting here in mid to late April, we've eliminated about 55% of the physician office visit activity in the United States. As some states started to open up on May 1st, you can start to see a slight uptick here and things starting to return. And that's on office visits. Emergency department activity, again, starting on March 15th, and it's pretty much dropped consistently all the way through till it bottomed out at the end of May. And ER activity in the United States is off around 50%. Something that has been striking and jarring to those in the healthcare industry is, where did all the strokes go? Where did all the STEMIs go? Where did all these acute conditions where people show up in the emergency department, they disappeared. And there'll be a lot of postmortems done in terms of, did these people really not, the prevalence of having these acute conditions like strokes and TIAs and STEMIs really go away because people were sheltered at home? Or did people expire at home? We don't know. But the ED visit volumes and the acuity of cases that typically show up really cratered over the last 2 months. Outpatient visits cratered even more. So again, big change starting on March 15th. But if you're in mid to late April, you've lost 55% of your hospital outpatient visit activity. Concern I had early on that I started voicing with the administration on March 1st was, it's one thing to be concerned about having sufficient resources to be able to meet the potential surge for treating COVID. The bigger concern to me was the financial viability of our delivery system, because what we did is we put a moratorium on all elective case volume across the United States. And we basically, you can see from these graphs, eliminated 50% of the clinical activity in the country. We did it all within 2 weeks. And you saw hospitals furloughing staff. I happen to be on the board of a public hospital company with sites in 28 locations in 14 states. And we had to furlough about 1,000 staff prior to going bankrupt, because hospitals didn't have the liquidity to weather the downturn and have the day's cash on hand to make payroll when you eliminated all the clinical activity. So I think it's important to remember that we have hotspots. New York, New Jersey, Southern Connecticut area, Detroit, New Orleans and Louisiana. But this is a big country, and those hotspots are isolated and don't mirror what we've seen all across the United States. And the longer this persists without people consuming medical care, it really does put in jeopardy the clinical solvency, the financial solvency of our delivery system. And that's a very real concern of mine. If I put these together and run this through the end of last week, you have office, hospital, outpatient, and ED on the left axis, normalized to around 1, normalized to January. And on the right axis, you have telehealth. And this is one of the most striking changes that's come forth as a result of the move, as the shutting down of America. You can see that effectively telehealth was de minimis in the United States, in large part because to get paid a reasonable rate, you needed to go and see a provider physically. But starting on March 15th, CMS relaxed the compliance and the criteria around provision of telehealth. They relaxed regulation across state lines and who could provide. They did a number of things, including changing the reimbursement rate. And what you saw is a 40 to 80-fold increase in the use of telehealth in the United States. I have done 2 telehealth visits with my wonderful providers at Vanderbilt using Zoom since March 15th, and everybody has run to telehealth. The peaks and troughs you see here in the yellow line reflect weekends. Telehealth actually peaks on Mondays, rises over the weekend, and it craters during the week. So there is this substitution effect between office visits and telehealth. But one of the most important things will be, what does telehealth look like as part of the US healthcare landscape on a go forward? I talked to a lot of delivery systems who are very focused on what does our outpatient physical footprint look like post-COVID? We've all gotten used to consuming interactions on Zoom or WebEx or Microsoft Teams. You know what? It works pretty well for a lot of things. And we knew going into this, we do about 1.5 billion outpatient visits in the United States per year. And it had been estimated by the CDC and AHRQ that you could probably do a fully 1/3 of those via telehealth. That's 500 million encounters per year could be done via telehealth. So given that we've all been ushered into consuming interactions on a video platform, I think that this is going to be part of the permanent fabric. I'm not saying it's going to stay at the same level it is right now, but there's little question that telehealth will be a much more important part of the healthcare delivery landscape post-COVID. And that's going to present economic challenges to providers. Because most providers, when you go see your physician, wherever they are, Centennial, HCA, Ascension, Vanderbilt, you're going to see your physician, and then they're going to do other things. They're going to have they're going to do a lab test. They might do an image. In short, the technical and ancillary revenue associated with consuming medical care is an important part of the economic equation. But if I'm sitting in my recliner at home and I just did my visit with my dear Dr. Richard Hawk at Vanderbilt, he's not going to send me downstairs to get a chest x-ray or get an image. And a lot of those ancillary forms of revenue are going to change and go away. So thinking about what the economics are going to be following this is going to be very interesting for the healthcare delivery setting. I'm going to show you unpacking this now from the national level, looking at the state level a little bit. And I wanted to highlight for you the fact that, we've got basically 6 states, the Northeast, New York, New Jersey, Massachusetts, Pennsylvania, Connecticut, Maryland, all up there in the Northeast, that account for over half of all the confirmed cases and 2/3 of all of the deaths that we've had in the United States compared to the remaining 44. So this is highly variable by state, and I'll show you by county as well. So let's look at something that I see in the data and that might explain some of this variation. We know there is a relationship between age and mortality with respect to COVID. I took our claims data here as of yesterday and looked at the age distribution by state. Green is people under the age of 20. Yellow is 20 to 40, orange is 40 to 60, red is 60 to 80, and the dark red is 80 plus. And if you look over on the left, the percentage of the population in Idaho that we see as having COVID is 25%. It's quite high. If you look on the far right, Nebraska has 2.5% of the population who has COVID is over the age of 80. Similarly, in Nebraska, the vast majority, 47% of the population there is in the age of 40 to 60. So the age distribution here is very different with respect to who has those cases. It's not enough to say what are the cases. We need to understand something about the composition of those cases. Nebraska, my understanding anecdotally, is that you had a bunch of people in meatpacking plants in Nebraska who were diagnosed with COVID. And that's reflected in them being working age. So I think that's one thing that's noteworthy. The second thing is that if you're the prevalence of COVID in the under 20 population is really quite de minimis. It's been pointed out that Alaska is doing quite well in terms of their performance around COVID, and people have raised, is this due to inherent social distancing? And that might be part of it. It's also the case that Alaska has a very young population. 33% of them are under the age of 40. And you have very few who are over the age of 80. So I just wanted to put this out there that I think there's an important age relationship that might color this a little bit as we go forward. So let's look at some states. So this is unpacking. I've got here 2 states. Let's see, New York and Tennessee. Tennessee on the left, New York on the right. Tennessee because we care about it because, well, that's where we are, or many of us are still here. And New York is because it is the focal point, it is the epicenter. The top panel in blue is office visit activity, and then ED activity, and then hospital outpatient activity. And it's important to note that fully 2/3 of the COVID cases that I see in our data of 280,000 people are not in hospitals. They're being treated and diagnosed not in hospitals, but in outpatient settings, urgent care, office visits, skilled nursing, and other sites of care. So this is not a hospital-driven story. But you can see that, Tennessee and New York both observed this decline in clinical activity across all conditions. Tennessee, we dropped to about 50% of our pre-COVID activity. New York State probably dropped to closer to 30% of their pre-COVID activity. We see in Tennessee there's a little spike there in ED activity in kind of early mid-April, but ED activity in New York continued to trend downward. I think there's maybe a little bit here that it looks like we were kind of trending down prior to New York City trending down. Here's 2 more states, Michigan and South Dakota. I picked these two states not randomly. Michigan, because Governor Whitmer has been quite strident in ensuring that people don't engage in any activity, and has gotten some heat for that. Whereas the governor of South Dakota never actually issued a shelter-at-home order and basically said, go about your business, if you will. Be careful, be prudent, and whatnot. In Michigan, they've scrubbed off about 75% of their outpatient activity. In South Dakota, it's still down 50%. So even though the order wasn't there and it wasn't advanced by the governor, you still saw this massive change in clinical activity in the country. And again, you're starting to see it ticking back up in both Michigan and in South Dakota as of last week. How about we look at Tennessee? Let's go into county level. So we got Davidson and Williamson County. This is the central part of where we sit here. I'm sitting in Davidson County right now. And pretty similar kind of picture. Both cratering in terms of demand, with an uptick that we see in Davidson County in the last last week or so. Again, it looks like there was this is across all conditions, a rather marked increase in ED activity in Williamson County in mid-April. But those are those two counties, and two more, just to show you a difference. Shelby County down, which is Memphis, down in the southwestern part of the state, really didn't drop nearly as much as you saw happen in Davidson and Williamson counties. They lost probably about 30% of their clinical volume, but it stayed pretty close. And ED visit activity, again, the spike in mid-March is interesting in a number of our counties, but Shelby exhibited that spike. And then Hamilton, I believe, is down near the Chattanooga area. So the story varies a little bit based on county. Returning to my point about telehealth, I had some conversations with Intermountain as of late and talking about their markets. And here's looking at some counties in the greater Salt Lake City area. The top panel is telemedicine encounters, and the bottom is office visit activity. And you can see that it goes from the telehealth activity in these counties around Salt Lake City really is de minimis, is almost non-existent, and goes from 0, if you look at Salt Lake County, up to around 1,500 encounters. And prior to COVID, or March 15th, they were doing about 15,000 visits per day, and it dropped to probably around 7,000. So you had about a 50% scrub off in visits, and you had telehealth increased from 0 up to around 1,500 encounters per day. So, I mean, that's you lost about 7,000 and you gained about 1,500. So there's a partial offset there in telehealth. I mean, in my mind, I look at it as 1,500 over 7,000 in terms of as I'm looking across markets. Weber County, they went from 10,000 down to 4,000, so scrubbed off 60%, but only backfilled out with about 600 telehealth visits per day. So that's what I wanted to show in terms of my graphs and what I see going on. And I'm glad to, being mindful of time, open it up to questions and things that you guys might have on your mind, things that I'm continuing to work on, or things that might be of interest to all of you.
Hey, Larry, I've got about the rate of people across the entire population that are asymptomatic. You said in the Trousdale study, they saw 98% of people that were asymptomatic. Is that reflective of the general population? And if not, why do you think that is?
Yes, so you know, there is this focus on testing out there. What matters is who you test. And, and all the testing's happening very haphazard in a non-systematic way by county and by state. And if we were randomly testing everybody, we would get a different picture than if we were to be testing just those people who were sick. And so 2 points I hang on to is that one is we sit here with 1.3, 1.4 million cases today, but many of those are asymptomatic, one. Two is that from the random testing that's been done in communities in New York State and in Massachusetts and in Santa Clara, California, when you randomly test people, you find a much higher COVID positive rate. You know, Santa Clara, the folks at Stanford said the number of people who are positive could be 50 to 80 times the number of reported COVID positive cases. If that's the case, it's unclear to me what the utility is of testing. I will tell you that I had a bug and I got tested and I was negative last week. That doesn't mean I'm negative today, because I flit about. So from a practical standpoint, the focus has been on testing. It doesn't do anything to change the clinical trajectory of a patient's course of treatment. And when we don't know the fundamentals of who's being tested, it's hard to put that in a broader context. So if it's just the sick people are showing up and getting tested, you're going to generate a very different number than if you randomly walk out on the street and pull people off of 21st Avenue and test them. So I have a very difficult time making sense of the testing results at scale. See, any other questions people have?
Hi, Larry. I just wanted to ask something in line with the Medicaid aspect. I'm just assuming that there will be an expected surge in like Medicaid enrollments happening in a lot of the states just because like there's a decline in like employer-sponsored insurance. And also with the states not getting as much revenue, tax revenue, like I'm just assuming that there's going to be significantly increased like Medicaid costs to a lot of the states. And how is it being addressed at the policy level, this expected rise in Medicaid costs?
Yeah, so Richard, there's a number of parts to this. We are going to see the single biggest spike in health insurance in the uninsured population in U.S. history right now. We've probably eliminated 30 million individuals who were employed with employer-sponsored health insurance of some form, and now they're going to be uninsured. And now they're going to be showing up at healthcare providers who are going to be having to figure out, what do I do with them? It's going to create significant revenue cycle problems, and it is going to create very significant financial challenges for U.S. healthcare delivery. One of the biggest questions is, how soon are people going to voluntarily come back and consume medical care? My supposition is that in cities like New York City, nobody is going to go back to a hospital until they feel safe. And that could take a very long time for people to feel safe going back there. If, however, you are in Knoxville, in Knox County, where they've had very low case rate, I think demand is much more likely to come back quickly. But the longer that we remain shut down, and the more people are unemployed and they're dealing with income insecurity, I get very concerned about the economic impact. We know from the literature, and we have one of my colleagues here at Vanderbilt, Kip Viscusi, who's done all his research on the statistical value of a life, as well as the relationship between income and mortality. And it's suggested that for every $100 million you scrub out of a nation's wealth, it ends up costing one life. Okay? If we've taken out 5 trillion, $10 trillion of wealth out of this country, that's 50 to 100,000 lives right there. I work in the space of addiction treatment. I'm the chairman of the board of a medically assisted opioid treatment company with 22 locations. We haven't been able to treat people for opioid addiction. I was reading this morning that they expected as many as 70,000 additional Americans could die of drug overdoses and suicides this year because of the shutdown. So it's more than the direct effect of the COVID. This is going to have very far-ranging impact on people's health. And somebody just asked, is addiction treatment deemed non-essential? No, addiction treatment is deemed essential, but you have staff who are unwilling to go and supply it. Medical care providers who are concerned for their health themselves, and so they're unwilling to go and be in these clinics in these communities. And so there's labor challenges here as well. The Medicaid issue, Richard, is going to be a real issue. Right now, the administration is working on how do they get the funds out the door to providers to backstop them financially. As part of the CARES Act, there was $100 billion set aside in the first wave to go out the door, and I was party to some of those conversations, helping them figure out how to get that money out the door. So the first $30 billion went out based off of last year's fee-for-service Medicare allowed charges. And subsequent tranches are continuing to come out the door. But that will only last so long. And if we are shut down to July and August, and we don't get the clinical volumes back, that's not good. The industry is not going to be able to withstand that injury for a protracted period of time. You've got physicians. We've got about 1 million physicians in the United States, surgeons who basically lost all their income. And most providers are independent practitioners operating their own businesses. They've lost all their volume. So we do need to get the activity back in play. Other observations, questions?
I had a quick question regarding your emergency department numbers. Have we seen an actual reduction in actual acute cases, or are we really kind of seeing a highlight or an indication of the relative misuse of the emergency department across most hospitals?
So John, I mean, clearly we've a lot of the low acuity stuff isn't presenting, but I mean, I can send you a bunch of papers that people are very confused by, because the acute stuff, the heart attacks, STL elevated heart attacks, STEMIs aren't presenting. Strokes aren't presenting. So these are acute cases that should be in the ED and aren't there. And we don't know why. And maybe it's because if you're sitting at home in your recliner and you're not going outside, you're not getting a heart attack because you're not mowing the lawn. Maybe that's it. But it's unclear. But there has definitely been a reduction in the acuity there, no question about it.
Hey, Larry, I have a question. It's
Professor.
Luke. Hey, now that providers are getting reimbursed for COVID-19 patients, are you seeing a spike in the data of people presenting or people being classified as COVID, like deaths? If you have a heart attack and I test positive, are you seeing that in the data?
Well, it's hard for me to see it in the data, Luke, in that the ICD-10 code for COVID-19 was aligned temporally with when the payment change came. So it's hard for me to disentangle the presence of the condition versus the financial incentives associated with treating it. I will say that, yes, there is a financial incentive to codify an inpatient as COVID-19. And I do call into question the deaths, whether these deaths were due to somebody having COVID-19 or whether somebody died and they happened to have COVID-19 at the time of their death. Right now, I think there's a lot of fuzziness in a lot of the numbers that we're using to make policy decisions. And Ron just chimed in, and I saw Ron Ron, you raised this issue. The state of New York's had no reported pneumonia deaths since the payments began. The last time I looked, and I need to go back and check this, I looked at this, the CDC has ELINet, which is the illness influenza reporting net, looking at daily influenza cases. And what you saw is that on a typical year, we'll see 30 to 40,000 deaths per year of COVID. I mean, for flu. Odd year is 60,000. As of, I don't know, when I looked at it 3 or 4 weeks ago, there had only been 5,400 flu deaths in the United States because everything was being classified as COVID. So maybe it's true that we don't have the flu deaths, and maybe they truly are all COVID-19, but it's really aberrant in terms of when you look at the data series, the prevalence of influenza. So, all right, well, if being mindful of time, you all been very kind to endure along with me here. The data, I'll get much more complete data. Right now, I'm using my early real-time data feed. And starting the end of this month, I will have my full data assets, and I'll be able to tell really granular pictures about how things are changing by provider, by specialty, changing prescribing patterns, all kinds of different things. And so I'll be doing that as well. And so with that, I'll turn it back over to you, Ishan.
Thank you so much, Professor. Great session. Thank you everyone for joining. Also, we do have a session tomorrow at 1 p.m. where Professor Frobe will be giving his take on the current situation. So we look forward to seeing you there. For the incoming first years, we are having a few troubles with sending out these invites to your email. So check Slack, and we're going to be posting the details there. For everyone else, you should have gotten an invite in your email. We look forward to seeing you tomorrow, and thank you everyone for joining.
Thank you all.